Without wasting much time, I would like to talk to you about the difference in the mechanism of action of all the intra-articular injections that we use for osteoarthritis of the knee, and looked at the current evidence for us to make an informed decision. Someone just asked, what is the pathophysiology of osteoarthritis? Sometime back, I think Dr. Telang asked. So knee osteoarthritis is not simple wear and tear. And what I would like to highlight here is that most of the papers which are there in the Western literature, they talk about primary osteoarthritis, which we see less commonly in our country. So all this data has to be taken slightly in perspective with our practice as well. So the basic mechanism is inflammation, and what we are trying to dampen with this intra-articular injection is we are trying to dampen the inflammation and the pro-inflammatory cytokines or the inflammatory cascade that follows. So let's start with the corticosteroids as the intra-articular injection. So basically cortisol is endogenously produced in the body. Synthetically manufactured are two esters of this cortisol is methylprednisolone and triamcinolone acetate. They are basically made by two different companies. Mechanism of action is more or less the same. Duration of action, the Kenalog or triamcinolone acetate is slightly longer as compared to methylprednisolone, especially when used intra-articularly. What they do is basically they alter the B and the T cell immune function, they inhibit the phospholipase A2 pathway, and therefore that decreases the inflammatory cytokines. It also says that because it dampens the inflammation, it kills the inflammation, therefore it also promotes the synthesis of the hyaluronic acid production, concentration, and the fluid viscosity. So this is indicated when the knee is slightly swollen. There is some evidence of effusion, there is some synovitis which is present. Previously, people used to give more than one injection, but generally, by and large, people are now restricting to single injections of methylprednisolone. Either you can give a 40 milligram, or sometimes you can go up to 80 milligrams, and you can dilute that with a local anesthetic. So it is generally, most of the surgeons tend to mix it with a local anesthetic. There was a thought that you need to use two separate syringes, but it has been shown that the crystals do not crystallize, or there is no problem with mixing with the local anesthetic. So you can put it in one syringe and then inject. The problem is that after with corticosteroids, there is some skin depigmentation, cutaneous atrophy, fat necrosis, which can be seen, especially when the patient comes for a knee replacement. You can see some depigmentation. Those are the hallmarks that the patient has taken corticosteroids in the past. There was a concern with cartilage breakdown and that the steroids or these local anesthetics are toxic to the cartilage. This happens only in massive doses. This does not happen with the doses that we are giving in on a single shot basis. So if this is given as an infusion or in massive doses, especially in animal models, it has been shown that it is toxic to the cartilage. Moving on to the next one, which is the viscosupplementation, the polymers or the hyaluronic acid. So basically it is an essential component of the proteoglycans. It entangles between the collagen fibers and it gives compressive strength to the articular cartilage. So in vitro, the hyaluronic acid is manufactured either by using the recombinant DNA technologies or from the rooster comb. So it is of animal origin. It increases the viscosity of the intra-articular fluid and also decreases the inflammation. And therefore it gives as decreases the slight amount of friction which is there and helps mobilize the joint, lubricates the joint. There used to be 3 injections which used to be given at an interval of either 3 weeks, 6 weeks or 3 months, but nowadays we get them in a one single 6 ml syringe. The most popular brand is Synvis one, but there are not a lot of generics which have come to the market. Now what we have to remember is whether they are high molecular weight like 6 million Daltons or low molecular weight. The high molecular weight definitely are more efficacious, they are more popular and they are better, so they are the ones to be used. There can be a slight risk of flare-up of inflammation after we give the injection, but it is still lesser than what is encountered with steroids. We come to the PRP injections next. PRP, what is PRP? PRP is basically any volume of plasma which has got more platelet concentration as compared to the normal peripheral smear or the normal blood which is there. PRP injections are to be given 3 injections over 3 weeks. They have got various growth factors, vascular derived endothelial growth factor, fibroblast growth factor, the tumor growth factor, and these growth factors basically have regenerative capacity, so they also act by killing the inflammation, promoting growth, and therefore they are supposed to be counterprotective, and they would stimulate the endogenous production of hyaluronic acid is what the theory is there behind it. Currently, the FDA has not approved it for intra-articular injections. We have all been using it for plantar fasciitis, for tennis elbows, for enthesopathies, for different sides of the body, but except the joint, intra-articular injection is off-label use. So PRP by and large can be leukocyte rich or leukocyte poor. So what we are interested in intra-articular is leukocyte poor. The adverse effect are there can be some transient swelling, but this is still less if you are using a leukocyte poor PRP. Now, there are various companies which supply PRP kits. Like, for example, the sports medicine guys have Arthrex, there are Indian manufacturers, there are a lot of local manufacturers who supply. But what we have also seen when I was preparing this talk and talking to a lot of people, most of the people have started manufacturing or getting PRP within their own hospital setups, speaking to their pathologist. So basically, you take some 15 ml of blood or whatever volume of blood you require, you spin it with your pathologist. That's the first spin. The first spin gives you a buffy layer of platelets. You isolate the buffy layer of platelets, put them into another sterile container, spin it again. That's a hard spin or the second spin, and that gives you a platelet pellet at the bottom. And this platelet pellet is a concentrated platelets that can be mixed with the rest of the little amount of plasma, and that gives you your PRP. So this is how you make PRP in your own pathology lab or in your own hospital. Now the problem is, why did people start making on their own? Is because all these different companies, they had different activating factors, they had different speed at which they used to spin, they used to have different speed at which they were isolated. So there was no standardization, and that is where the problem came. Now we have gone one step ahead. Now this is a product called Osinext. It is available in city of Bombay. It is made by Wockhardt. It is sort of a in-house or Atmanirbhar Bharat kind of a product. This is one step ahead than a PRP. It is growth factor concentrate. So in which they are providing you a syringe. They are providing you a medium in which the platelets are physically sort of broken down and the growth factors are released, and then what we get in a syringe is a growth factor concentrate. So they have done some studies, they have published in lesser known journals. I've spoken to a few of the authors, and they said that though the numbers are very less, it seems a little promising. There is no harm in giving that. Stem cells, it is very new. I personally have not used any stem cells intra-articularly. We have used stem cells for AVN, but yes, they are available in India right now. They are currently quite exorbitantly expensive. In my opinion, I have not come across anyone, except for Dr. Mudit Khanna, who worked with Osinext in the previous slide. He has used only 2 or 3 cases where he has used adipose-derived stem cells. So let's look at the literature. So what the first thing we go to is the Cochrane reviews. The Cochrane reviews suggest that viscosupplementation for knee osteoarthritis, it provides pain reduction. It provides pain reduction better than a placebo. So this is very important that they have compared it with a placebo, and it is slightly better than steroid. So most of these articles are published in journals which are dealing with sports medicine, physiotherapy, general practice, article, sort of where the audience is basically general practitioners who also inject in the Western world. Very few articles are published in Journal of Arthroscopy, Journal of Arthroplasty, or our Bone and Joint Journal. So I'll try to focus on our orthopedic specific sort of aspects that we want to see. So what it clearly was evident was there is no mention of gait improvement, or generally people are saying there is no improvement in the gait. However, the pain scores and the WOMAC scores, they improve. If you have to see a trend over previously it was all steroid compared with HA, but nowadays we are seeing the PRP and the sort of biologics also coming into the play in sort of publications. This is a QR code of an article which was published very, very recently. It's 2024. It's from EFORT, and I think this is a very landmark and a good article where they have done a very exhaustive meta-analysis. Now, to again summarize, they have looked at some 3,500 titles, out of which they have arrived at only 35 sort of studies. Though there was no risk of bias, there was no indirectness or publication bias, there was inconsistency in every single paper. There was imprecision in every single sort of trial. And what we see here, the quality of evidence is moderate to the best. So if you have to compare corticosteroids versus hyaluronic acid, there is no difference in the initial period at 6 weeks, 3 months and 6 months. However, the VAS score at 12 months in the hyaluronic acid group was better, but it was not more than the MCID. MCID is a minimally clinical sort of difference that the patient can recognize, but this patient cannot recognize this clinical difference. But if you have to compare PRP versus the steroid, the difference was better, and therefore the PRP scored better than the steroids in the short, mid, and the long term in terms of pain and functional scores both. So it was clinically relevant to the patient, and the patient perception was better in the PRP group as compared to this thing. So if you look at the Journal of Arthroscopy, this same group of authors has published 2 articles in the same journals, and one is comparing the PRP, second is comparing the viscosupplementation. So in the PRP, so basically there were improvements in the patient outcomes at the midterm, but what was not clear is whether it was single injection, double injection, single spinning, double spinning, or there are various factors which are not very clear. In terms of viscosupplementation, so to summarize, in the intra-articular injection, if you compare the hyaluronic acid versus steroids, hyaluronic acid is better. If you compare it with NSAIDs, there is no difference. So whether you are using NSAID, oral NSAIDs or intra-articular hyaluronic acid, the outcome is similar. And if you are comparing with PRP, PRP has a slight advantage over here because they have more robust outcomes. If you compare that PRP versus bone marrow aspirate concentrate, the BMAC or the bone marrow aspirate concentrate is showing more promise. Coming to the question, can we mix this injection, steroid and hyaluronic acid? There is no justification of mixing these 2 injections, so it is not to be done. Steroid and PRP, they will contradict each other, so it's not advisable. PRP and hyaluronic acid can be combined in a particular injection. So what the AOS recommendations are for steroid, it is inconclusive to recommend because there is no evidence, so it does not recommend for or against. For some reason, hyaluronic acid is not recommended by the AOS in spite of the evidence which is working in its favor. While for PRP, they say that there is not enough data to recommend for or against the use of PRP. When there is no evidence, surgeons come together and try to form a consensus group. So this is another recent paper where the consensus group from the European hospitals was formed. And what they said that in which patients do we consider injections is that in early osteoarthritis, you can consider the injection only if the patient wishes, or if there is a failure of previous treatment, or there are severe comorbidities or contraindications to any of the first-line therapies. Or in case of severe osteoarthritis, you can do that only if the patient is having mild or moderate pain. Again, if the patient wishes to undergo an injection, or if there is a contraindication to any surgery. So lastly, what I would say, our practice is what is in sync with what the recommendations are, that you do it only for symptomatic patients who have failed a more than 3-month trial of a conservative treatment. Offer it only on the first visit, only if the patient is having any contraindication to NSAIDs or is not willing to take any painkillers or medicines, or the patient is unfit for surgery. The VAS course and X-rays should be done, some sort of imaging should be done to make sure you're not treating anything else. And viscosupplementation can be used only to decrease the NSAID consumption. It is not going to alter the natural history of disease. That is all I would like to summarize from whatever I have read. Thank you very much.